Hi there. Thank you so much for joining me. Today, we're joined by Dr. Alain Moreau, and he is the director of the Montreal MECFS Collaborative Research Center, which is established by Open Medicine Foundation. Today, we're going to talk a little bit about the research progress and updates from the Collaborative Center. Thank you so much for being here. So there's just so much exciting research coming out of the Montreal MECFS Collaborative Center right now. And most recently, you are working on developing a diagnostic tool and prognostic test to discriminate ME/CFS from fibromyalgia. So can you just tell us a little bit about this new tool?
So we, as you know, we initially developed a panel of 11 circulating microRNA. So microRNA are small, non-coding RNA that we are able to measure in the blood. And we identified this diagnostic panel based on our capacity to induce post-exertional malaise using an inflatable cuff, so that we are referring to our stress test. And the difference between the patient at rest and following the induction of the stress test give us some kind of signature to allow us to identify who is suffering of ME, and also to be able to categorize or stratify the ME patient in different subgroups. So we decided to test if we can apply the same panel to other related conditions having some kind of overlapping symptom, although post-exertional malaise is specific to ME, not to fibromyalgia. So we started with fibromyalgia samples at baseline, and we saw that we have a very opposite picture. So at baseline in fibromyalgic patient, all these 11 microRNA were very, very low in terms of their level in the blood. So, and we push our luck a bit further, because as you may know, there are ME patients that have fibromyalgia as a comorbidity. So you may have ME and FM altogether. And what we found is that when you have both, you have a kind of intermediary expression. So for most of these microRNAs. So the upcoming papers will be about this description, that the same panel that can distinguish ME can also distinguish people suffering of fibromyalgia and other having both. So why this is important is because there are maybe ways to better treat FM only versus having both, or versus having only ME. So this is very important because, for instance, when you start to really have a more objective tool that can accelerate the diagnosis for clinician, especially family doctors that can be or lack the expertise or experience dealing with people suffering of ME or FM. So this is good. And also we saw that in our cohort in Montreal, we have a lot of people that say, oh, I have ME. And we now, with the test, we said that, yes, you have ME, but you have also FM, which may further exacerbate some of your symptoms, especially the ME plus FM exhibit a more, let's say, a higher pain score than people having a purely, if I may say purely, because it's never purely, there are all other comorbidities often associated with ME.
Of course.
So they may have some less pain. And also we find some few ME patients that in fact they are fibromyalgic. So they have only FM. And this is maybe important for them as well as for their attending physicians. So this is something important to categorize the patient with the right cohort.
Absolutely. So actually, you published a fascinating study, and it was called The Profile of MicroRNAs in ME/CFS and Their Relation to Symptom Severity and Disease Pathophysiology. So just to break it down even more, this is so fascinating. Can you please explain just a little bit about what microRNAs are and why they are important to study when examining the pathophysiology of ME/CFS and or fibromyalgia patients?
So let's start with the very basic stuff. So for instance, our blueprint for every cell is the DNA. So this is where the reference, so this is our database, if you wish. And this database is used to send some message So this is what we call a messenger RNA that will be eventually translated in a product, which are the protein. So, and this is the protein that will make us alive, and that we also, when they are modified, too little or too high, or they are maybe changed to be cleave and have a shorter protein, or with other type of modification, we end up with some disease. So the short microRNA are part of a family of what we call non-coding RNA. So they are not used to relay the message from the database. So they are produced, and in fact, they are very powerful, what we call regulators. So they are attaching to the messenger RNA, often at the end, and this attachment blocked out the decoding, if you wish, inside the cell. So when one microRNA attached to one single messenger RNA, it prevents the production of the protein. To just further add one more layer of information of complication, wow, is one single microRNA can target up to 200 different genes.
Wow.
And one gene can be targeted by more than microRNAs. So this is a kind of equilibrium, and this microRNA can be modified by your diet, by some medication, by oxygen levels. So if you live in the top of the Himalaya or Everest mountain, you will have a different profile than if you live on the beach at the level of the sea.
Oh, wow.
And and that's why the microRNA are more and more used in molecular medicines as a diagnostic and prognostic tools, because they are very powerful, very stable in different biological fluids, blood, urine, different type, whatever your favorite fluids is. And we can measure them. And they are responding to different stimulation like exercise.
Right.
So that's why we built our concept and experimental design based on the capacity to induce in a very standardized way post-exertional malaise, because this is a hallmark symptom of ME, and to see who is increasing or who is decreasing, and from their own baseline. So whatever they are taking, different medication or supplement, we don't really care, because each individual being is on control.
Thank you so much for explaining that and breaking that down a little bit. So that study is very interesting. So you are manipulating, what you're trying to do is get a post-exertion malaise response from patients. So can you explain a little bit more about how you do this, the setup of that study?
So again, there are different ways to induce that.
Right.
You can decide to put people on treadmills or doing some stationary bicycling and doing effort, which is done in what we call the CPET, which is you try to reach your 80% maximum effort, and you do that and try to repeat that on 2 days. But we know that moderate to very severe patient cannot do that type of exercise.
Right.
So, and most of them are housebound. So we need to reach out them, and we develop a portable technology to allow that. So that's why we come out with the idea to have an inflatable cuff, okay, that can be applied to the arm. And technically, this machine is giving you a therapeutic massage. But on ME patient, when they are resting on their bed, okay, it's like that I'm making them running a marathon. So during 90 minutes, so normal people are receiving a massage, but for the ME patient, we are making them a bit sicker because they are developing the post-exertional malaise. But we try to find the right equilibrium, not having to call 911 after the stress test. And for I would say we test over 250 individuals so far, and we never had some issues about any emergency or so severe adverse effect that the participants have to go to the hospital. So everyone is aware that they will develop post-exertional malaise. Some of them not immediately or during the stress test. Some is at the stress test of PAM is developing the next day or next 48 hours. As you know, this is very variable from one individual to another one.
Sure.
And that's why we are following the patient over a week. So we have a kind of 5 days that we can continue to monitoring the patient to see how the patient will react and to what extent, and the differences between the pain. Some people will have some, let's say, change in their heart rate variation, having tachycardia events. Other will have more brain fog. Okay, so that's why measuring different parameters like the neurocognition, memories, and things during before, immediately after, and 5 days later to see if the individual recovered from what we induced is very important. So I think we are the only study in the world so far doing this type of longitudinal assessment using different parameters. So it's, and we are lucky because we are successful because we have true patient partners to achieve that.
Wow. See, that is very interesting because I know a big challenge with studying this specific patient population is that many of them are homebound or bedbound, so they cannot get to the lab. And you've been able to find a way to have the study be inclusive for the more severe patients by developing that cuff. So thank you for explaining that for us a little bit more. And I know what you just mentioned a little bit about post-orthostatic tachycardia syndrome, also known as POTS, which brings me into my next question. So one of the new studies underway at the Montreal Collaborative aims to develop an understanding of orthostatic intolerance and POTS in ME pathophysiology. So can you just explain a little bit more about this study?
So as you know, POTS are orthostatic intolerance. So let's start with orthostatic intolerance. So you may have orthostatic intolerance because you may have some kind of endothelial dysfunction, but not all orthostatic intolerance will lead to tachycardia, okay? But most of people having orthostatic intolerance may also develop tachycardia, okay? So orthostatic intolerance is a more global view about many vascular, cardiovascular issues that are affecting ME patient. And of course, POTS is probably one of the most debilitating symptoms. So how to explain simply what is POTS for a non-expert is often when you go from the horizontal position, so you are in your bed and you go going up. So the horizontal position, okay, you will see that you will find hypotension. You will maybe either you will faint, or often your heart will compensate by accelerating the cardiac rhythm, and you develop tachycardia to compensate this symptom. This the same thing might happen if you are on the standing position for too long, over 5 minutes or even 10 minutes. You cannot endure that, and you will see that your heart will start to increase suddenly and erratically often. So this is why it's very debilitating, because you start to you don't like this sudden change and you don't have any control on that. And some tachycardia is not just for a few seconds. We are taking some several minutes that people might endure that. So it's very debilitating symptom. So now, what are causing POTS? Even in condition where there is no ME, but people are suffering of POTS, which is also possible.
Sure.
So we don't know, okay? So the only genes that's being identified with POTS, it's a gene called SLC682, which encodes for a norepinephrine transporter called NET. So in a rare family where on multiple generations, they have very severe tachycardia or postural orthostatic tachycardia, they find some rare mutation. But this is true for very, very rare family where, okay, so, but the vast majority of people don't have a mutation in that gene. But there are other ways that that gene can be modified. And this is, again, the role of microRNA. Right. So we find one microRNA in our diagnostic panel, which is called MIR155P. And this microRNA is targeting that gene. So if you have a very high level of this microRNA at baseline, so at rest, you may be tachycardic most of your time because you reduce your level of this norepinephrine transporter, so the cell cannot uptake and your level of norepinephrine will be very high. Some people have a relatively okay level at rest, but as soon as they have some effort, their microRNA is increasing, and this is where they develop tachycardia. So this increase, okay, in reaction of post-exertional malaise is associated with immediate tachycardia development. So we find two things with this microRNA. If you have an elevation, you develop POTS. But we also find the opposite, where we have a very, very low level of this microRNA and we still have some POTS. How can we explain that? It's because the regulation of this gene is very complicated. And there is a repressor that is also targeted by the same microRNA. So when the microRNA is high, I block the repressor. Normally the repressor will increase the transcription. So I will have more copy, more message, if you wish. But because I have high level of this microRNA, I will block the translation. So the message won't produce protein. But if I'm very low, I will have a high level of this repressor, and now I will block the number of copy of this. So two distinct mechanisms that explain why too little or too high of this microRNA leads to the same phenomenon, the same what we call in our language phenotype. You have POTS.
Right.
So for the patient or the clinician, this means that we need to watch that microRNA more closely. And also we need to find ways where if it's too little, we need to block the repressor, and there are now drugs on the market that can do that. And if you have too high, we need to either block this microRNA, okay, or find other ways to do that. So this is where we are, I think, in our progress to understand ME by targeting the most debilitating symptoms, is that we need to do precision medicine.
Right.
Because we are not only clinically speaking, but now at the molecular level able to separate patients. But now for specific symptom, even by looking about the same markers, we now can just, what is the meaning to have too little or too high and you end up with the same disease? Mean that there would be a different drugs or different ways to treat that. So that will be not a single magic bullet to treat everyone. That's why precision medicine is now very important, because if we try to put everyone at the same time and we try drug A, we will figure out that drug A won't work for most of patients, and that will be a failure. So precision medicine is essential to not only personalize the treatment, but to make sure that we have a more profound understanding of what is happening.
Wow. So I think that's such an important point, because with ME/CFS and so many other diseases as well, personalized medicine is so important, because one person with ME/CFS is not necessarily going to look like the next person with this disease. And there's so many people that have different comorbidities. And it's interesting, though, that microRNAs are implicated in so much of the disease process. So thank you again for explaining that. And I'm really interested to hear more about this research going forward with the microRNAs. So I also wanted to talk a little bit about something that's top of mind for everybody right now, which is long COVID, of course. And I'm wondering if you could speak a little bit on your long COVID, your study that is comparing long COVID and ME/CFS patients. If you could just explain that a little bit for us, and then talk about what you are learning about it or what you hope to learn.
So as you may know, and it's highly anticipated, that a certain number of long COVID patients, unfortunately, will develop ME. This is not novel. We know that 75% of ME patients reported to develop ME following a viral infection or bacterial infection with either the regular flu or some more exotic viruses like West Nile virus, chikungunya virus, and other, including previous coronavirus like the SARS or the MERS. So we pay attention during this pandemic about, yes, we know that long COVID will be associated with a rise in the ME/CFS patient. So now, having said that, we use the same protocol to apply a stress test on long COVID. So we design our experimental approach first by investigating non-hospitalized long COVID patients, meaning that these people have either a very mild symptom or even asymptomatic symptom during the acute phase of the disease where they got the COVID-19 infection. And when they got a negative PCR result, okay, they were supposed to be cured, they start to exhibit either new symptoms or some symptoms increase in intensity and vary over time. So we select people that have a 6-month period of long COVID just to make sure that we are really targeting the right people.
Right.
And I can see based on the different tests and markers. So we are looking more or less at the same markers that we are looking for ME, starting with the microRNA, but we have also other circulating molecules that we are measuring. And we are, again, same principle. We are measuring at baseline and after the application of our so-called stress test. So, which I think reveal more effect than simply looking at rest what is happening.
Right.
And we saw a lot of similarities with ME patient. But roughly, I can tell you that when you look about the trajectories, okay, who will develop ME, who will develop other type of long-term sequelae like neurological disorders or cardiovascular issues, which are very different than ME. And so we can say 1/3 of them will develop ME. Roughly, this is what we measure in our cohort in Quebec. There's another 1/3 that will be split between 20% neurological sequelae as opposed to cardiorespiratory sequelae. And the remaining 1/3 will, they are lagging behind, and that will, maybe some of them will take up to 18 to 24 months. But the good news is we think they will fully recover, okay, if they are not hit by a flu or again, a second or a third infection with the coronavirus, because you know that with the US variants, you can possibly got that COVID-19, even if you are vaccinated or you got an infection before. So every 6 weeks now, you can get a new infection, okay, unfortunately, with the US variant. So this is the latest reports are telling us. But this group we are seeing, especially we are measuring the neurocognition every 2 months. So we have patients that now we follow over 18 months. And we saw that some of them improving every time. But others, we saw either a bad, stable situation or even something that are worsening also. So this is one way that we are following patients with this different ways to think about long COVID and especially with what we learned from ME patients. So what we try to do here is to learn from the long COVID to try to mitigate and eventually reverse that situation. We don't want them to remain permanently affected. But what we are developing with the long COVID cohort will be applicable to ME patient. So this is for us a unique window of opportunity to confirm some markers. So we have some markers where they are too high in ME, they are too high in long COVID, they are associated with the same symptom severity. So those are, I think, the keepers, they are the biomarkers that we share and very important. But there are other markers that are more maybe specific for instance, for the neurological sequelae that have nothing to do with ME, so which is a good thing because we can stratify and separate both situations. But nevertheless, if you think about 10 to 30% of people that got COVID-19 are at risk to do long COVID, and 30% of them will end up with ME, that would be millions of individuals that would join the current cohort of ME worldwide. So we don't want them to join the pack. You don't need more friends there. We just want to try to do something to prevent this progression. And again, we don't know if some variant will be more, let's say, prone to leads to long COVID and ME. That's because we don't have enough data, and this is a type of data that we don't have access, because when we got the patient isn't so-called infection-free. So we cannot do sequencings to assess the nature of the variant or the subtype of variants that they may got. And you cannot necessarily expect from a different population perspective what type of variant this population got at that time. So most of the long COVID patients that we got are from the either Delta or Omicron, at least in Quebec.
Mhm.
So we don't have the latest variant yet in our court, but eventually it's something that we should put on the dashboard to make sure that eventually we may end up with something like that.
So you do think it is important to examine the variant when you were looking at onset?
Yes, but this is a data that is not really available. And
Right.
again, when we are looking patients starting at 6 months post-infection, we don't have this information. So we cannot retrieve
Right.
it by ourselves. And this is not an information that is, is coming because it depends on the region. So not every patient positive for COVID would be sequenced. So you don't know exactly who is being infected by different variant. But eventually, it's a question that the clinicians and researchers are considering that whether or not some variant, especially a variant that creates some mild symptom, so they are more tolerable for the acute phase.
Right.
So is it meaning that because you are more able to tolerate that, you put yourself at risk of developing long COVID?
Right.
That would be a terrible situation because people now are thinking, and I have no proof of what I'm saying, but it's purely an hypothesis. But people are thinking that, yes, we are more infected often. The virus is more contagious. It's annoying, but we don't have a very sick situation where we are not necessarily dying if we're already being protected by vaccination, which is very important. So, which brings me to also the topic about ME patient that got the vaccine and improved their symptoms. Some people got a full remission during several months.
Yes, I've heard.
And this is about 30% of them. But in 70% of them, the virus unfortunately further exacerbate their symptom for a few weeks, which is okay, I think, if the vaccine can save lives. So it's better to remain alive than to die from a severe COVID-19 infection.
Right.
So we are very interested to try to work with people that got the vaccine and improve their symptom. Often they are newcomers, so we don't have the value of when they were sick and to test them, but I would be very happy to test them where they are in full remission and asking them to come back if in 6 months, a year, they are relapsing, and to compare the difference in the biomarker. So these type of patient partners are very important to us.
Right. So looking at the variant, as you mentioned, might be one thing that's important, although unfortunately data doesn't really allow for that right now. Another question I have about that is viral load. Do you think that the viral load a patient is exposed to might have a correlation with severity or whether or not they develop ME/CFS or long COVID?
This is quite, I think, well known, at least with the previous variants. Okay, so that's why the hospital and hospital workers, they were in the first line, so they've been overexposed to higher viral load, even with their protecting gear. If you are working in a hospital where you are, let's say you are in ICU where you are only full of COVID-19 patient, with or without the protective gears, you increase the likelihood to be infected and to have higher dose of a viral load here. This is not, it's not just a question of to be exposed. Yes, you increase your risk. It's also, there are some genetic predispositions that can lead you to increase your viral load, and because you won't build as a solid response that will protect you. And of course, if it's the case, you will end up to be hospitalized possibly and probably needing an ICU treatments to save your life and to get rid of the virus. Of course, now with the new, not only the vaccine, but now with the new medication that are more specific for COVID-19, what we are seeing is a decline of patients hospitalized in ICU. There are still too many, but there are less because, and as soon as people with, especially people having some vulnerabilities or risk factor, they are treating right away with the first day of the infection with the new drug to prevent ICU hospitalization. So they might be staying in the hospital for a few days or a week, but that would prevent a further aggravation. So again, more intense you'll be your acute phase with the COVID-19. It's something that, yes, we know that some ICU patient will end up with ME, but will be a mix of the intensity and severity of treatment, and also intensity and severity of the infection that leads to that type of sequelae, as opposed to, let's say, the people having ME as a consequence of their long COVID is because they had mild or asymptomatic symptoms, and we don't know exactly if something predisposed to long COVID, which is also something. It's not. I don't think it's fair just to say that it's because you have, let's say, mild symptom that you are more at risk to do long COVID. It's more complex than that.
Mm-hmm.
There are reasons that people will have, let's say, moderate or mild symptom is because their viral load or their initial exposure were reduced. They have adequate vaccination booster, and they don't have additional complication or vulnerabilities. So that explains why you do mild symptoms and unlikely to even do a long COVID. We are working also on a different other epigenetic marker involving DNA methylation changes. I have a strong suspicion, we don't have a proof yet, but the preliminary results are going in that direction, that it's possible that some people have some alteration in their what we call epigenome. So I told you that the DNA is the database, is the blueprint, but you may have modification of this blueprint. So not creating mutation. So I don't change the alphabet in the DNA, but I'm adding some postmark, which are methyl group. And when a methyl or too many methyl are present, okay, this region of the DNA becomes silencious, and the genes in front of this is not expressed. So that's explained why we have all the information in every single cells in our body, but the neurons are not producing bone, and bone are not producing brain cells, because some part must remain silencious where others are activated to match their role in the body. So that's what we call the epigenome. So this is very cell type specific. And we start to have some, let's call it another type of signature, if you wish. And we saw that the long COVID altogether, independently of the trajectory, they share some mark or signature that might lead to it or explain why they did a long COVID. Mm-hmm. And now we're in the process to look in the healthy population. And fortunately, thanks to Open Medicine Foundation, we initiated this project long before the pandemic. So we have a few cases of healthy people 2 or 3 years before the pandemic. And now we try to figure out if these changes pre-exist in the methylome before the pandemic. And now we will verify if these people were at risk of developing long COVID when they got being exposed by the virus later on. So it's a long shot. It's a very bold hypothesis, but if we prove that, now we may have a mechanisms to try to explain and work on the prevention side, say who is at risk of developing long COVID and eventually maybe ME or something else versus people that are not at risk. So I'm not saying that will happen, but we have some preliminary results that seems to go in that direction. But let's be patient to see if we will fully prove that very bold hypothesis. But if it's the case, that would be very exciting.
That would be very exciting. Prevention is so important, especially with the millions of people that are now at risk every day when we get a COVID infection, because unfortunately, it seems that although vaccination is very important, it might not guard against long COVID.
Exactly.
So thank you so much for joining me today and explaining all of the fascinating research that's going on at the Montreal Collaborative. I'll be interested and really excited to hear more about the work that's coming out of the Collaborative Center, and we will be sharing more as time goes on. So thank you again for joining me today.
Thank you very much for the opportunity. Stay tuned. More to come.
Yes, stay tuned, more to come. And now it is May Momentum. So if you would like to support the efforts of the directors such as Dr. Moreau here, please consider donating to our May Momentum campaign, as this research is so important. And people like Dr. Moreau are working so hard, so urgently to figure this out and to find the answers. So thank you again, Dr. Moreau.
Thank you, and thank you all for your support. Okay, so we look forward to find a cure to NAB as soon as possible. Thanks for your help.